Afternoon session, GU Oncology 2. I would like to ask for the first speaker, Professor Josie Karam from United States of America. He is going to present cytoreductive nephrectomy. Is it a valuable option? Please, Professor Karam.
Okay, good afternoon, and thanks again for the invitation to be here. It's a pleasure to be in Egypt for the first time. And my talk this day is to tell you about cytoreductive nephrectomy and if it's a valuable option or not. Being a urologic surgeon, I think it's a valuable option, and I'll try to convince you that that's the truth and try to tell you when it's a valuable option, because it's not always a valuable option. But these are the recommendations that the European Association of Urology have published last year. And in general, they recommend for stage 4 patients, and these are patients who have metastatic disease, that they should undergo cytoreductive nephrectomy if they're appropriately selected. But they don't really go into very much details about this. But that's what my talk will be about today. These are the NCCN guidelines from the United States, recently published, and they keep updating them several times a year. And they've divided the patients into 3 different categories, as you can see here. So the first category, if the patient's primary tumor... if the patient's primary tumor is technically surgically resectable, and if they have a resectable solitary metastasis, then the patient should undergo cytoreductive nephrectomy plus metastasectomy or excision of the metastatic disease. The second category of patients, if they have a primary tumor that's surgically removable, and if they have multiple metastases, then they should undergo cytoreductive nephrectomy and then have systemic therapy to treat the multiple metastatic disease. And the third and the final category, if the patient is medically unresectable or surgically unresectable, then they should only receive systemic therapy and no cytoreductive nephrectomy. So let's go into some details here. So let's talk first about the cytoreductive nephrectomy in the immunotherapy era. And I'm talking here about the old immunotherapy era. This is back in the interferon days. And we do have phase 3 randomized clinical trials that clearly showed that surgery works in this setting. This is the SWOG trial published in the New England Journal of Medicine in 2001. And you could see here, the line looks a bit faint, but you can see on the upper panel here, the patient's survival was better if they had both surgery plus interferon compared to only interferon. And in the same year, the EORTC, led by Dr. Mikish, published this in The Lancet, almost the same thing. Basically, the upper curve that you could see it here, it's surgery plus interferon compared to interferon alone, again showing that surgery improves the survival of patients with metastatic kidney cancer if you combine it with interferon therapy. And these are the combined results for the both studies. So this is not a new study, but all they did here is the combined results of the SWOG study plus the EORTC study in a sort of a meta-analysis, if you will. And they found that the overall survival for surgery plus interferon was about 13 months compared to interferon alone, which only provided about 7 months survival, again confirming this benefit in the old immunotherapy era. Now, an editorial also published in the New England Journal, and this is not a phase 3 study, but this is an editorial published from the UCLA group that looked at 89 patients, and all these patients met the SWOG criteria to enter into the clinical trial. So they said, well, we have a similar cohort of patients, but these patients were treated with interleukin-2, high-dose interleukin-2, and not interferon. As you can see here clearly, patients who had surgery plus interleukin-2 did much better than those who had surgery plus interferon, and those did much better than patients who had interferon alone. And again, here showing that surgery plus interleukin-2 has a better activity. And that's really what's been used for a long time before the targeted therapy era came in. So now we don't live in the interferon era anymore in kidney cancer. So what's going on in the targeted therapy era? This is the tyrosine kinase and the mTOR inhibitor era, and more recently the PD-1 and PD-L1 inhibitors. So currently we don't have any finished, completed randomized trial on cytoreductive nephrectomy in targeted therapy era, but we have 2 trials that are ongoing. This one is called the Carmina trial. This is mostly by the French group, and what they're doing is they're randomizing patients into 2 groups. So this is very similar design to the SWOG trial and to the EORTC trial. So they're randomizing to nephrectomy followed by sunitinib versus sunitinib only without the use of nephrectomy, with the primary objective here is being overall survival. Now the study's been accruing for almost 7 years, and it's expected to take several more years to finish accrual. This is the other trial. Again, this one is not published yet, but this one has a different design. So what they're doing here is they do nephrectomy. It's also randomized. So the patients have nephrectomy followed by sunitinib, or they have sunitinib, then nephrectomy, and then sunitinib again. And the primary objective here is progression-free survival. Now the study started about 6 years ago, and it actually just stopped accrual last month, and it stopped accrual at about 99 patients out of the 458 patients that were originally designed. From talking to the principal investigator of this study, Dr. Axel Becks, it looks like we will have some results hopefully in 2017 or 2018. So again, these are the only 2 trials ongoing in the targeted therapy era discussing the role of cytoreductive nephrectomy, and we don't have the results at this point. The question is, when I go to my clinic next week, and I will definitely have 1 or 2 cytoreductive candidates, what do I tell these patients? What do I do while waiting for their third time results, while waiting for the Carmina results, which will take at least 1 or 2 more years to come up? Now, what we have are retrospective data, and I'll show you here a lot of retrospective data supporting the use of cytoreductive nephrectomy in the targeted therapy era. This is an expanded access trial using sunitinib, and what you could see here is the objective response rate is better. It's 18% versus 9% in those patients who had prior nephrectomy. Again, in a retrospective study, but this is a large study of more than 3,000 patients, showing that if you've removed the kidney, your objective response rate is better. This is the same study, and here looking at progression-free survival, the green curve is those patients who had nephrectomy and then had sunitinib. The blue curve are those patients who did not have nephrectomy. And you see a similar trend for overall survival as well. And again, the green curve is those patients who had surgery, nephrectomy, and the blue curve is those who did not have surgery. Again, in a retrospective fashion, showing a survival benefit for patients who've had surgery followed by targeted therapy. This is another study, again, another retrospective study. This one is smaller, but same concept and same findings. The right curve here is those patients who had nephrectomy, compared to the black one here, those who did not. And the survival is about 20 months versus 9 months, almost double. Now, when you look deeper into the details, you see that the survival benefit is mostly in patients with Karnofsky performance status of more than 80. So patients with poor performance status did not benefit from cytoreductive nephrectomy, and you can see that on the right-sided panel here, which makes sense. And in the immunotherapy era, the clinical trials, they included mostly patients who had performance status 0 or 1, mostly patients with good performance status. This is a large multi-institutional retrospective study. This is the International Metastatic RCC Consortium. And again, you could see here that the survival in patients who had surgery, and the orange line here, is better than those who did not have surgery. Again, very similar numbers, 20 months versus 9 months. Again, you see it here, 20 months versus 9 months. So the results are at least consistent, but all of these are retrospective. But we definitely have to take a closer look at cytoreductive nephrectomy. I mean, all these results are nice. It shows surgery works in retrospective setting, but we have to dig into the details a little bit deeper. So let me take you to this graph that I showed you earlier. This is the meta-analysis, the combined analysis of the 2 trials with surgery plus interferon versus interferon alone. And if you take a close look at this red line that I drew here, this is at around 6 months. If you draw a line up, you could see that about 30% of patients who had surgery were dead at 6 months after surgery. And about 45% of patients who had no surgery were also dead at 6 months. So this tells you that there is a patient population that definitely is not going to benefit from surgery. So if we're doing cytoreductive nephrectomy, as shown in this trial, for the general population, it seems to work. But for an individual subset of patients, surgery is not helping. And you can see here, 30% of patients did not benefit from surgery because they didn't live more than 6 months. So this tells us that we should be even more careful. You know, this trial selected patients very carefully, but even those who we think might benefit from surgery, we still have to look deeper into the details to see who we can spare an operation that they might not need. So how can we do that? So we can use preoperative factors as a biomarker to tell us who might benefit from surgery, and there's different ways to do this. This is a study from our institution, and what we did is we compared 556 patients who had surgery to 110 patients who did not have surgery. And you can see here, the red line is those who have surgery. They had better outcomes than those who had not. But in our center, we're pretty aggressive about doing surgery. So the patients who did not have surgery did not have it because there was a reason they didn't have it. They were too sick, poor performance status, etc. So what we did is we said if the patients who had surgery that lived exactly like those who did not have surgery, those patients obviously did not benefit from an operation. And we found that a cutoff at about 8.5 months is where we declared that if the patients who had surgery didn't live that long, obviously they didn't benefit from the operation. So what we did is did the analysis, and we found these 7 factors that predict a poor outcome in those patients who had a nephrectomy. And this is what we then did. So when we used different criteria, you could see that patients who have 0, 1, 2, or 3 risk factors, they have a reasonably good overall survival, going from about 13 months to 40 months. But those who had 4 or more risk factors had poor survival. And these are patients who had surgery. So then you look at this curve here. The red curve is those patients who had nephrectomy and had 3 or less of the risk factors present. And here, I don't know if you can see it, but there's actually 2 curves. And these 2 curves are exactly the same survival. One of the curves is those patients who did not have surgery, and the other curve is those patients who had surgery but had 4 or more of these risk factors. Again, telling us if you have a lot of these risk factors, you will not benefit from nephrectomy. What we then did is we established a different study, and we worked on a nomogram and included low albumin and high LDH. These are 2 very simple. We always get these factors preoperatively, and we can predict which patients might benefit from surgery. The C index, or the accuracy, is about 0.76, and this was recently externally validated by colleagues from the Netherlands. And if you think that the 0.6 or 0.7 are low and not very accurate, when you look at the IMDC criteria or the HEN criteria, or when you look at the Memorial criteria that we use in metastatic patients, they actually have very similar C index of 0.6 or 0.7. And the low albumin has also been validated by a different study from the Fox Chase and Vanderbilt that it's an established risk factor. This is from the different study from the IMDC study, and they use different criteria here, 6 criteria, similar to our study, which we use 7, but they're slightly different. But the concept is the same. If you have 3 or less of these risk factors, your survival will be better than if you have 4 or more of these risk factors. Other things that have been looked at as predictors before surgery are tumor burden. So the more tumor you can remove with cytoreductive nephrectomy, the better the outcome of the patient is. So if the tumor in the kidney is 3 centimeters, this patient's probably not going to benefit from cytoreductive nephrectomy. But if the tumor is 15 centimeters in the kidney and they have a few metastases, then these are the patients who will probably benefit most from surgery. We've looked at T-stage as a predictor of outcomes, and we know that in patients who have T4 or invasion to other organs and metastatic disease, these patients are going to do very bad after surgery. Their survival is almost always less than a year. So in general, in these patients, we don't do surgery except for purely palliative reasons. Non-clear cell histology, there's studies that say its outcomes are good with surgery. Some studies say they're not good. So it's very unclear at this point if surgery is beneficial or not in non-clear cell histology. There are several studies that looked at hospital factors and found that patients who are treated in hospitals who do a lot of the cytoreductive nephrectomy have better outcomes in these hospitals just because of the expertise of the surgeon, of the anesthesia team, of the ICU team, of the internists available to assist after surgery. So in general, it's recommended, but it's not mandatory, of course, that these surgeries are done by experienced surgeon and experienced teams. Age is another very important factor, and we know that the older the patient, in patients with cytoreductive nephrectomy, the worse the outcomes, and in general, 75 years of age is kind of the cutoff, but it's not a very exact cutoff, but this is what most of the studies have found. Now, in addition to using simple preoperative factors to tell us who might benefit from surgery, we can do it in a different way. And I presented one of these studies yesterday. We can use response to therapy as a litmus test. This is one of the earlier studies from Axel Becks, and what they did is they included 16 patients and treated them with low-dose IL-2, GM-CSF, and interferon. And if the patients had a partial response or stable disease, then they had nephrectomy. In this patient population, survival was about 11 months. And if they had progressive disease, they did not have surgery. And that's a good thing because the patients died at 3 months afterwards. So if we did surgery, we probably wouldn't have prolonged the survival very long. So this is one way to pick. Another study by the same group published 4 years later, also 16 patients. This time they used interferon alpha only, but the same concept. If you have partial response or stable disease and you have surgery, you have reasonably good outcomes. If you have progressive disease on therapy, then no surgery, and you can see the outcomes here are 4 months. And I don't think this is because they didn't have surgery. I think it's because the tumor is extremely aggressive and surgery was not going to help these patients. This is the study that I presented yesterday that we did at our institution at MD Anderson. 50 patients treated with bevacizumab. If they had partial response, stable disease, and even progressive disease, but with good performance status, these patients had nephrectomy. And if patients had poor performance status, then they did not have nephrectomy. I'll try to go through this very quickly just for the sake of time. We looked at another litmus test. We said, if we give a patient medication, here in this study we used sunitinib, does an early response of the primary tumor, is that a predictive factor or a prognostic factor as far as telling us who might benefit from surgery? And this is the patient population. And we found that if a patient is going to have a response, and they're going to have it within the first 60 days in general, and this is where this red line is. And here with univariable analysis, you could see that patients who had more than 10% shrinkage of the primary tumor, they have the better outcomes, and especially if they have that response in the first 60 days. And when we looked at this in a multivariable analysis, this is the factor that was important. A more than 10% tumor shrinkage in the first 60 days was associated with a better outcome. And let me show you here. So in this patient population that we studied, you could see that the Memorial Sloan Kettering criteria did not really separate the patients very well, and this is intermediate and poor risk. However, if we applied this newly described factor, which is tumor shrinkage of 10% in the first 60 days, you can see that these patients had a reasonably better outcome, and you can see it on the right side here in the green color. So just to give some final arguments for surgery and to say what the con side would say. So you hear a lot of debates that surgery should never be done because we don't have any phase 3 trials in targeted therapy era. And, you know, some people say that, but I don't think that's completely true. We have these data. We know that surgery works. So I don't believe the argument that we should not do surgery anymore until the results of the clinical trials come out. And the problem is, let's say we do the Carmina trial, the Certam trial, the results are published, but then let's say nivolumab or pembrolizumab or atezolizumab or avelumab or one of those drugs becomes now the first line. So does that mean now we have to make a new clinical trial with these drugs and forget about the Certam and the Carmina? And it's going to be very hard to do a clinical trial with cytoreductive nephrectomy every time we have a new drug on the market to prove it works with these new drugs. And do we really need, or can we even do that for every new drug that comes out on the market? Or can we simply test surgery as a concept of cytoreduction with whatever best systemic therapy we have available at the time? And I'm going to give you the reverse argument. So if you look at all these clinical trials that have resulted in approval of these drugs for first-line or second-line therapy in patients with kidney cancer, and I've done the calculations here, you can see that 90% of the patients enrolled on these clinical trials already had a nephrectomy done. So does this mean that these drugs can only be used in patients who have their kidney in place or who have the kidney removed? So we really don't have any data on these drugs if they work in patients with the kidney in place. All these drugs have been studied in clinical trials that have 90% of patients already with a nephrectomy. So saying that surgery only works in the immunotherapy era is almost like saying that these drugs only work if the kidney's already been removed. So it's kind of a circular argument which we should be very careful about doing. So do we really need to repeat all these trials and have the patients keep their kidney in the meantime? Because that's the only way we can prove that these drugs work in this setting. So the two questions I have in my mind when looking at this topic of cytoreductive nephrectomy is, number one, can we pick which patients will do poorly, whether surgery is done or not, and avoid surgery in these patients? We know these patients exist. As I showed you earlier, about 30 to 40% of the patients we think are good candidates don't really benefit from surgery. And I think we can do that with a combination of using preoperative risk factors, using pre-surgical therapy as a litmus test, or doing molecular analyses. And there are some studies now trying to see if we can use BAP1 as a marker for patients if they can benefit from cytoreductive nephrectomy or not. And the second question in my mind is, in those patients who are not expected to do poorly, otherwise in patients who we think are going to do okay, does surgery help? And these are the patients who really need to be randomized. So how about this as a new clinical trial? So this is not a real trial, this is just my imagination, just to kind of put it here for you. So let's say we're going to do a clinical trial. We'll get all patients with stage 4 kidney cancer, and we'll give them whatever best systemic therapy we have available at the time. Doesn't matter if it's targeted therapy, immunotherapy, or whatever it is. And in those patients who have progressive disease and poor performance status, then these patients should not have nephrectomy. And this will answer this question. However, in those patients who we give them therapy and they have partial response or stable disease with good performance status, if we want to randomize, these are the patients who should be randomized to surgery versus best systemic therapy. And we don't have that trial designed yet. So my last slide is the conclusion. No? Okay.
No, continue, please, Osama.
30 seconds.
Yeah.
Okay, so to conclude, I think that surgery still has a role in the current era, but we have to select the patients well. We have prospective data in interferon, we have retrospective data in the targeted therapy era. This is how we can predict which patients might benefit from surgery using the preoperative risk factors, using response to therapy as a litmus test, and I've shown it here for you. And we are currently awaiting the trial results, but I think surgery still should be done in selected patients. We should not completely forget about surgery. And these are the patients in general who recommend cytoreductive nephrectomy for. They're younger patients, if they're clear cell histology, if they have good performance status, if they have limited metastatic disease, if they have 3 or less of the risk factors that I described to you, and preferably if they're having surgery in a high-volume center. But patients who are in other categories doesn't mean that they should not have surgery. So we have to really individualize each patient individually to see if they qualify for surgery or not using the factors I described to you in this talk. Thank you for your attention.
Thank you very much, Professor Josie. Any questions from the floor? Please.
The mic, please.
That's a good question. So as far as the metastasis, we know that patients who have more than one metastasis, they do worse than patients who have one metastasis only. But that doesn't mean that we cannot do surgery on those patients. So if they have a small lung lesion or a small lung lesion with a small pancreatic lesion, it's still okay. We can still do cytoreductive nephrectomy if everything else is the same. So having more than one metastatic site is not a contraindication to cytoreductive nephrectomy. As far as your second question, it should be a radical surgery. Now, the difference is if a patient has the kidney with bulky lymph nodes visible on CT scan, if you're doing the nephrectomy, then you should also be doing the lymphadenectomy. Now, in patients who have negative lymph nodes on CT scan, doing the nephrectomy alone is okay because several papers retrospective have shown that doing a lymphadenectomy in general does not improve survival in patients who have metastatic disease. There are several papers that have published this. There's only one paper that showed benefit, but it only had 17 patients in the patients who had in the lymphadenectomy arm. So in general, if you're doing surgery with positive nodes, you should remove the nodes and the kidney. If the lymph nodes are negative, then removing the kidney alone is okay. Of course, with negative margins. Radically.
Any other questions? Thank you, Professor. Thank you. Next speaker is Professor Ashraf Zarloul. He's going to present robotic cystectomy, NCI Egypt experience.
At the very beginning, good afternoon. I'd like to thank the organizing committee and Dr. Hisham Al-Ghazali for allowing me to share with you our experience, initial experience at robotic-assisted radical cystectomy at NCI. Yesterday in the keynote lecture, Dr. Hassan Abul-Ainin rose a lot of criticism against minimally invasive and robotic cystoprostatectomies. He has a lot of worries that entail the inability to perform an unblocked excision of the bladder and all the involved tissue. Secondly, there is limitation in doing a proper pelvic lymphadenectomy, and for sure there is no way to do an extended lymphadenectomy. And the nerve-sparing cystectomy it may harm for increase in the local regional recurrence. And lastly, when we use the minimally invasive, we deviate the patient the benefit of orthotopic bladder. I hope in the next few minutes I can defend myself and explain to you how a robotic-assisted cystectomy is a safe one. Minimally invasive surgery is being incorporated more frequently into urologic practice, replacing many open procedures, and robotic-assisted prostatectomy is now the gold standard in the treatment of adenocarcinoma of the prostate. In recent years, minimally invasive approaches such as purely laparoscopic and robotic-assisted radical cystectomies have been suggested, and several recent reports suggest that the RARC is safe and feasible, and it may be associated with several intra and perioperative advantages in terms of blood loss, hospital stay, return bowel functions, and preservation of physiological functions. However, it is still a controversy on the adequacy of robotic approach to radical cystectomy, mainly due to limited data available in the literature. We started, as you know, our robotic system in 2011 at NCI, and it is not only the sole system in Egypt but in Africa. And we managed to perform 30 cases of cystectomy using the Vinci SI system. And at the very beginning, we put the patient in a position, and after padding and securing and preparing the patient in the supine position, we put him in a steep Trendelenburg, 20 to 30 degrees, then doing the docking, and the docking is taxing the patient cart to the OR table overlying the patient and connected it to the ports. And port placement start with a camera port aiming at 20 to 24 centimeters from target organ. Here is the bladder, and then at least 8 centimeters from the camera port to place the R1, R2, and R3 of the robot, and 2 or 3 assistant ports can be done. The dissection steps is dissection, isolation, and clipping of the ureters, posterior peritoneal incision behind the bladder, posterior dissection. I'd like to go through this busy lateral peritoneal incision alongside till the lateral edge of the medial umbilical ligament and posterolateral ligament control, nerve sparing procedure was called scissor, and then last step doing the anterior peritoneal incision, placing the specimen in the bag and put it at the end of the procedure and retrieve it through a mini incision, doing pelvic lymph node dissection along the iliac vessels. After that, doing urinary diversion, and if there is no intracorporeal urinary diversion is planned for, a mini incision 6 to 8 centimeter midway between the umbilicus and the symphysis pubis is performed, and an extracorporeal urinary diversion is done, and we managed to do 3 cases of intracorporeal Studer pouch in this. As we got our results, the mean age is 55, and the pre-cystectomy pathology, 63% transitional cell, 30% squamous, and 6.7% adenocarcinoma. And as regard the clinical staging, about 53% of the cases were T3A or more. There is no selection bias. Previous abdominal surgery in 3 cases, and there is no preoperative chemo or radiation therapy. As regard the OR time, doing cystectomy with extracorporeal, the mean is 6.5 hours, while doing intracorporeal, mean of 9 hours. And diversion type, intracorporeal, as I told you, 3 cases Studer, and extracorporeal, you can see that we do ileocecal bladders, Studer pouch, and rectosigmoid. So about 74% of the cases have already an orthotopic bladder substitute. Nerve sparing is done in 70 cases, unilateral or bilateral, and pelvic lymphadenectomy is standard pelvic lymphadenectomy in 86%, while 13% underwent an extended pelvic lymphadenectomy, and the estimate blood loss is about 400 milliliter. As regard lymph nodes removed, the mean for standard pelvic lymphadenectomy is 17, extended pelvic lymphadenectomy about 20, and positive margins in 2 cases, one at the proximal end of the ureter, and we remove one more, and another one in relation to urethra. And in these cases, we do urethrectomy and give the patient a conduit. As regards the post-operative complications, delayed recovery and severe irritability in the early cases from brain edema in 2 cases, chest infection 2 cases, DVT 2 cases, leakage in 20% of cases, 10% are major leak, and they managed expectantly. As RARC, I'd like to share with you posterior dissection, opening the peritoneal flexion between the bladder and the rectum, and by magnification up to 10 times and 3D vision, we can manage simply to dissect and expose the seminal vesicle and vasa efferentia, and then holding the non-villier fascia and open it. And this is the yellow coloration, with that of the rectal fat. Then we can manage, as you know, the plexus starts behind the seminal vesicle and prostate and the rectum. We dissect carefully to preserve the nerve supply from the very beginning, going laterally, and dissection of the peritoneum and sweeping the fat to expose the lateral ligaments, and using the vasosealer or clips Then we shift to remove the fascia overlying obturatus internus, and then dissection of the remnants of neurovascular bundles laterally till the apex. Then the most crucial portion is the posterolateral attachment of the prostate, and here avoid to use electrocautery because this may harm the neurovascular bundle. We use an IGILUC or IGILUC. On the lateral side, this is the neurovascular bundle. Then we shift lastly to the anterior dissection. We left the bladder, attach it to the anterior ligaments. This is the two lateral medial ligaments, and we remove the urachus, opening the areolar tissue and exposing the extraperitoneal fat down to open cave of radius, and then to reach the apex of the prostate. Then this is the puboprostatic ligaments well seen. We control the dorsal vein complex by placing a suture 3/0 vicryl using the knot technique, sliding one. Then we divide the dorsal vein complex to visualize the urethra, put an H-shaped stitch to occlude the proximal portion of the urethra, avoid spillage of urinary contents, and this way we can remove the bladder. As regard extended pelvic lymphadenectomy, the other concern that arose yesterday, we already performed the same technique we applied in open surgery here. I don't have to remind you that all of us have been taught to do proper cystectomy after Professor Dr. Ismail Sibai, who taught every surgeon in the region, not in Egypt. And we didn't obviate the way we do it in an open fashion. Here, skeletonization of the iliac artery vein all around. In the standard pelvic lymphadenectomy, we stop at the bifurcation of the iliacs. In the extended, we reach the bifurcation of the aorta. Here, the obturator nerve has been exposed and obturator group of lymph nodes meticulously removed. And we extend dissection to the bifurcation of the aorta here. And this, all the lymphatic basin have been removed, and we marcate the left from the right side with using clips. At the end of the procedure, all lymphatic contents were put an endobag in an endobag and removed at the end of the procedure. And we repeat the same on the contralateral side. What about the other concern about intracorporeal Studer? For sake of time, I'm doing it double speed. At the very beginning, we doing the anastomosis, urethrointestinal anastomosis, and during an Echelon doing the excision, sparing 20 centimeter of the distal ileum, and then during the Echelon doing intestinal anastomosis, side to side, and occluding the tip. Then start opening the pouch, and doing the circulate of the Studer pouch. For those who are surgeon in the audience, they know how difficult Studer pouch creation is in the open surgery, but the meticulous use of the third arm in the robot-assisted cystectomy makes the platform stable and make the procedure looks easy. Here, doing the usual Wallace technique, suture the posterior wall of the ureters, and then removing the bottom and doing the retroiliac anastomosis. And by use of a catheter, we introduce a guide wire with our line stent, putting it into the ureteric ends.
To Ashraf, time, please.
Okay. So, it is feasible to do a complete unblock cystectomy with the use of the robot will not obviate the principles of oncologic unblock resection. We can manage to do an extended lymphadenectomy, and we can easily perform nerve sparing because we have good visualization. And all the worries that arose yesterday remind me with a simple question: how do you hunt a white elephant? It is very simple. The answer: painted in black, I'm hunted like a black elephant. Thank you.
Thank you very much, Professor Ashraf, for this very impressive techniques and videos. And any question from the audience? Yes, sir. Yeah. The mic is not working. The organizers, please.
عبد العزيز الجمل، معهد القومي للكلى. حاجه جميله جدا في دكتور جمال، اول سيريز شفنا من روبوتكس سيستكتومي. 3 اسئله كانوا: واي شودر؟ difference between pelvic lymphadenectomy and extended lymphadenectomy is 17 to 20. It means like 3 total differences. Is it worse efforts? I imagine most of your cases were T3, so I understand why you went to that. The last question, number 3, long-term follow-up and complication, and if any, mortality 30 days within a hospital stay. I imagine there's no mortality here, but I mean, how would you calculate your 30 days complication, late complication, and long-term follow-up with regard to neurovascular preservation?
We now put this. I'll start with the first question. First question: why Studer? Because Studer is a very intelligent way of orthotopic. The concept of the Studer. I am one of the first who applied this Studer in the late 80s. And the concept put by Dr. Studer is very convincing to me. And you have to do detubularized, no pressure pouch, which accommodate about minimum 500 to 600 in the early phases. And it is connected to a conduit, isoprostatic conduit, which is connected to the ureters, so there is no submucosal, whatever, all these things, it will end up in some sort of stricture of the ureter and it will damage the kidney functions. And the simplest and the safest way is a conduit. We learned it. This is a conduit attached to a detubularized pouch, no pressure pouch. And one of the cases we have already performed, I'm proud of it, is a kid less than 2 years, and he is still in his diapers. And we obliged to do for him cystectomy, and I did for him a Studer, and now he is 20-something. It was a rhabdomyosarcoma failed after failure. We should offer the patient the best quality of life. This is simply like this. If you search for the quality of life, you have to do an extra couple of hours work to provide it for your patient, so long as you can do it. Number 2, as regard we are following our patients. We still expanding our series. We have now subspecialties, and we have a team dedicated for urology. So after 1 year, we will publish our new series and the follow-up data.
Extended versus pelvic?
Extended pelvic. We have the problem with the pathologist as usual. We remove a lot. Actually, when you do a standard pelvic lymphadenectomy, you should have at least 30 lymph nodes. Extended more than that, but they don't go for a thorough examination and isolation of the nodes and examination, and we have this. We have to be honest and put it like we have in the study.
Big congrats.
Thank you.